Good evening, everyone, and thanks, Dr. Chitra ma'am and team ARC for giving me this opportunity to speak in this webinar, which has been conducted wonderfully till now. Eyelid tumors vary from small nodules to fungating masses, which can be life-threatening. So, it is very important as a postgraduate and even as a clinician to differentiate between these tumors so as to guide management prudently. What I would be discussing in this talk would be how to evaluate an eyelid mass, how to differentiate between a benign and malignant tumor, and how to differentiate between commonly encountered tumors in the clinic. Now, we all know that eyelid has an anterior lamella and a posterior lamella, and there are various structures which form these lamella. Now, eyelid tumors originate from these various structures, and the classification of eyelid tumors thus becomes simple to differentiate based on whether they are arising from the skin, the sweat or the sebaceous glands, the hair follicles, melanocytes, or various structures found within the eyelid. When we evaluate a case of eyelid tumors, history taking and clinical examination are the most important things because we can make a diagnosis in 95% of the cases just based on these two things. Systemic examination is prudent in cases of malignancies, investigations are needed in certain case scenarios, and surgery, histopathology, and follow up have a crucial role in malignant eyelid tumors. Now, as a postgraduate sitting in a clinic, if such a case walks into your clinic, how do you evaluate such a case? We don't forget the basic principles of Love and Bailey's surgery, where we know about the onset, duration, and progress of the tumor, the location of the tumor, that is, whether it is on the upper eyelid, lower eyelid, canthus is involved, or if it involves the lacrimal system as well. The extent helps us in prognosticating the disease along with the size, and also helps us to determine which structures are involved and which structures might be involved in surgery. You need to know the relationship of the tumor with the surrounding structures. Like in this case, you can see that it is very close to the lower punctum and the canaliculus. The surface of the tumor holds utmost importance because we can know about the characteristic of the tumor from the surface. A smooth surface indicates a benign tumor, while a bosselated pedunculate surface might sometimes be malignant. Fixity to the surrounding structures like the bone, skin is also a clue as to know about the orbital extent of the tumor. Feeder vessels and telangiectasias point towards a malignant tumor. Presence and absence of pigment can help us classify various tumors. And the anatomy of the eyelid margin and regional lymph nodes also should be examined in any case of eyelid mass presenting to the clinic. Second most important thing that you need to do when you are evaluating an eyelid tumor is how to differentiate a benign tumor from a malignant tumor. So in these cases, you need to look at the eyelid anatomy and the architecture as well. Destruction of the eyelid architecture as seen in this image with rounding of the posterior tarsal margin is very indicative of a malignancy, along with localized madarosis, telangiectasias, nodularity with pearly translucent margins. Ulceration associated with bleeding occurs mostly in malignant tumors. Effacement or distortion of the meibomian gland anatomy and the meibomian gland orifices, along with tarsal thickening. So, if there is a clue to all these things, it points towards a malignancy. Now, if you're sitting in a very busy clinic and you get these case scenarios, you might pass it off as a chalazion. But the most important takeaway message from this talk, which I'm giving, is you need to evert the eyelid in every and each and every case of an eyelid nodule, because sometimes an innocuous looking mass might turn out to be a polypoidal fungating mass beneath the tarsus. Sebaceous gland carcinoma is a great masquerade, and that's what we are going to start the discussion with. Usually, sebaceous gland tumors can be missed off as a chalazion, like this lady where she underwent an incision and curettage, and the tumor recurred bigger and faster after the incision and curettage was done. Eventually, she turned out to be a sebaceous gland tumor. Sebaceous gland carcinoma is very commonly seen in the Indian and Asian subcontinent. It is a relatively rapidly growing tumor causing distortion of the tarsal architecture. It arises from the Zeiss and the meibomian glands, and also can arise from the caruncle. Now, management of sebaceous gland tumor is very important because it has a higher recurrence rate than other tumors. It has a high rate of metastasis if there is a recurrence and if not treated well. And it can masquerade as either a chalazion or a chronic blepharoconjunctivitis as seen in the lower left picture. Management will be discussed in detail by Dr. Kasturi after my talk, but usually we take 4 millimeters margins, do cryotherapy at the edges, follow a no-touch technique along with intraop frozen section and Mohs surgery, and then histopathology usually guides further treatment. Preoperatively, in the evaluation, it is very important to do lymph node assessment and systemic metastatic workup in the form of a positron emission topography scan or either a CT scan of the whole body just to rule out any presence of metastasis before we start treatment. Sometimes sebaceous gland tumors can occur like this, where you cannot delineate the posterior extent of the tumor, and you can see that the tumor is spread beneath the fornix and is infiltrating the inferior fornix and has obliterated it. Now, this is sure shot sign of orbital invasion, but there are certain clinical pointers which can help you determine whether it has spread into the orbit or no. Ocular movement restriction, presence of proptosis or diplopia, ptosis, an evident orbital mass or fixity to the orbital structures of or the rim is a pointer towards orbital invasion, and an imaging in the form of either a CT scan or an MRI scan is prudent in such cases. As you can see that the tumor has invaded the anterior orbit, which is more evident on the axial cut, and these cases then either need neoadjuvant chemotherapy followed by excision or exenteration if neoadjuvant chemotherapy is not indicated. Second, coming to the most common tumor which is found worldwide but a lower incidence in India and dark-skinned individuals is the basal cell carcinoma. Now, basal cell carcinoma has a typical characteristic clinical appearance with pearly rounded margins and ulcerated center. It is usually pigmented, but there are certain variants which can be non-pigmented. It is also called as a rodent ulcer because of its locally infiltrating nature. So it infiltrates locally and doesn't spread systemically. The metastatic rate of this tumor is very low. Most common site is the lower eyelid, followed by the medial canthus. Sun exposure is one of the most important factors associated with a basal cell carcinoma. Now, beware that not all basal cell carcinomas involve the eyelid margin. There are certain basal cell carcinomas most commonly found on the lower eyelid skin, like this, where there is a lucid interval between the eyelid margin and the basal cell tumor. The four morphological forms of basal cell carcinoma are nodular, nodulo-ulcerative, morpheoform, which is more resistant to treatment because it is superficially spreading, and the cystic variant. Treatment of basal cell carcinoma is fairly straightforward, where you need a good surgical margin clearance. Prognosis is good and metastatic rate is low. There are certain forms of medical therapies in the form of imiquimod cream and cryotherapy for smaller lesions. And nowadays, sonic hedgehog inhibitors in the form of vismodegib are available for extensive loco-regional spread. They are not yet available in India, but they are FDA approved in the US. Coming to the third variant, which we see commonly, which is basically doesn't have any pathognomonic features, but is mostly a histopathological diagnosis, is a squamous cell carcinoma. These are rapidly growing tumors. As you can see, the upper slide and the lower picture, you can see that there is a growth within 5 days of the tumor. I had seen the patient first at this, and then you can see it has grown so rapidly within 5 days. It is highly metastatic with a very high recurrence potential. Also, on histopathology, it is very important to know about the perineural spread because perineural spread on histopathology warrants more aggressive follow-up because recurrence rate is very high. There are certain precursor regions which can cause squamous cell carcinomas like Bowen's disease, keratoacanthomas, actinic or solar keratosis, xeroderma pigmentosum, and radiation dermatitis. Now, not all malignant tumors or not all malignant looking tumors are malignant. There are certain masquerades of malignant tumors also, which could be benign in the form of pseudoepitheliomatous hyperplasia. These are basically benign tumors mostly due to fungal infections. And if not treated, they usually regress on their own. Sometimes these tumors also need biopsy from the edges because they can have squamous carcinomas, which can reside on the edge of these tumors. Now, coming to the benign tumors, which are commonly seen in clinical practice, I won't harp much on external and internal hordeolum, but it is very important clinically. I see a lot of referrals where they have been mistakenly labeled otherwise. So you need to know that an external hordeolum or a stye in layman's language involves the eyelid margin, and conservative therapy is usually sufficient for treating these tumors along with drainage of a focal pus point. While internal hordeolums usually involve the meibomian glands, there is a lucid interval between the eyelid margin and the nodule. It is usually painless, can be painful sometimes if there is an inflammatory change. Now, there are differentiating features between the both, which can be read in any textbook. Usually, internal hordeolums can be treated either with a straight incision on curettage or steroid injection, which has been recently tried for smaller lesions. Now, sometimes these chalazions can also trick you, and we sometimes see these giant chalazions which have a polypoidal fungating internal component. Now, we should not be fooled by these lesions and consider them malignant. This is again a giant chalazion which doesn't resolve only with incision and curettage and might require debulking and steroid injections from the anterior lamina. Seborrheic keratosis and squamous papillomas are again commonly encountered tumors. They are small hyperkeratotic lesions which may be sessile or pedunculated. Classical appearance is that of a button stuck on the surface of the skin. Excision with the help of radiofrequency cautery and reconstruction with flaps works very well for these tumors. Xanthogranuloma are again common benign cholesterol deposits which are found in individuals basically who have a tendency of lipid abnormality, or certain xanthogranuloma are hereditary in component also. They are notoriously recurrent even after excision and recur because of a deeper orbicularis component. Surgery, electrodesiccation, and chemical peels have been the mainstay of treatment. But not all yellow looking tumors are xanthelasmas, as in this lady, where you can see that she has yellowish plaques on the upper eyelid, but she has mechanical ptosis on both the sides, along with diffuse thickening of the upper eyelid skin and extension of the tumor beyond the upper eyelid fold. Now, this could be a tumor which could have systemic implications in the form of a xanthogranuloma. It has 4 variants, of which Erdheim-Chester disease has very poor prognosis. So you need to do a proper systemic workup if you have a suspicious xanthelasma, and immunosuppression and debulking along with local steroid treatments works well for these lesions. Imagine a small child, a young child, walking with these small central umbilications and pearly white tumors into your clinic. This is a crop of molluscum contagiosum. These are very contagious, are notoriously recurrent, and thus require very close follow-up. Extraction with the help of an extractor will reveal molluscum bodies which can be sent for histopathology for confirmation. If there are sudden increase in crops of these tumors and bilateral, you need to check the immune status and rule out seropositivity in such patients. Nevi are again commonly encountered tumors which are pigmented tumors along the eyelid margin. They can be acquired or congenital and usually transition from junctional compound to intradermal nevus as you grow in age. They appear at 5 to 10 years of age, grow during puberty, and stabilize during adulthood. They can be pigmented or apigmented. You can excise these nevus very well with a radiofrequency excision. Congenital periocular nevus again is a spot diagnosis. It can be either presenting as a nevus of Ota, where the eyelid skin is involved along with the V1 and V2 dermatome. It can involve the episclera and even the uveal tissue. 10% of these can be bilateral. And the most important point while dealing with these tumors is they need sequential follow-up for fundus evaluation in uveal tract evaluation, because 1 out of 400 of these tumors have a tendency to develop ocular melanoma. This is again a spot diagnosis, neurofibromatosis type 1, which shows either a plexiform neurofibroma, classical S-shaped eyelid, and multiple neurofibromas as seen. You need to do a proper systemic screening along with CT scan of the orbit and brain to rule out gliomas in these cases. Local excision of the big neurofibromas can be done, but otherwise mostly treatment is supportive. Vascular tumors cannot be left apart. Usually, vascular hemangiomas present at birth and involute by the age of 7 to 8 years. But there is a variant of vascular lymphatico-venous malformations or varices, which can present in the eyelid, which usually enlarge on Valsalva maneuver or straining and bending. They can be compressible, and a bruit can be felt on, or a pulsation can be felt if they are high flow arteriovenous malformations. They can be excised very well if they are small in size, or glue embolization can be done. If bigger tumors like these are suspected and which have a good flow characteristic, interventional radiology can help us in taking care of these tumors. The list of orbital eyelid tumors is unending, and I can go on and on. But due to time limits and to consider that we need to do it from a postgraduate perspective, one take-home message which I would like to give in a routine clinic is any eyelid nodule or bump, you always scrutinize and avert to look at the tarsus, because you could be looking at a sebaceous gland carcinoma, which can, in which time can matter. Thank you.